You have the ovary mobilized, right? You found your cleavage plane, and you start applying gentle traction.
And for a second there, it's peeling perfectly.
Exactly. But then suddenly the tissue tears. The field just fills with blood right near the hilum, and you have this split second to
Oh,
decide.
yeah. The classic dilemma.
Right. I mean, do you reach for the bipolar and risk, permanently destroying the patient's fertility, or do you step back? It's a visceral, super high-stakes surgical reality that you as a clinician face in the OR all the time when dealing with endometriomas.
It really is. You're constantly walking this tightrope between eliminating the disease to relieve pain and desperately trying not to decimate the patient's ovarian reserve.
Exactly. And that split-second decision is really the crux of modern endometriosis surgery. Welcome to this deep dive.
Glad to be here. We're looking directly at the tension between anatomical restoration and fertility preservation today. Because when you're operating on a patient with chocolate cysts, you aren't just treating today's pathology.
Right. You're directly influencing her reproductive options for tomorrow. So to navigate that tension, our mission today is to unpack a highly specific, fundamentally practical set of joint recommendations.
Yeah, we're analyzing a really comprehensive consensus document from the ESGE, the European Society for Gynecological Endoscopy, partnered with ESHRE and the World Endometriosis Society.
And what's great about this is that previous guidelines, they gave clinicians the what and the when based on evidence, but they frequently left out the granular technical details of the how.
Yeah, they left you hanging on the actual execution. But this document bridges that gap. It's entirely focused on the technical execution of different surgical methods for endometriomas in women of reproductive age.
I mean, we are exploring the physiological rationale behind specific techniques, the biophysics of energy devices, and the advanced strategies needed to really optimize patient outcomes.
Because the biological stakes are just incredibly unforgiving here, we know that surgery inherently damages ovarian follicles, right?
Yeah, you can literally track the unintentional destruction of that tissue through, post-operative drops in AMH and reduced AFC on ultrasound.
Exactly. Surgical precision is basically the only barrier between a successful excision and premature ovarian insufficiency, which means your strategy has to begin long before the patient is even under anesthesia.
The battlefield prep, right. A successful surgery starts way before the first incision.
Right. The guidelines actually treat meticulous preoperative planning as the very first operative step. So a bimanual examination and a high-quality pelvic ultrasound, or MRI, those aren't just for diagnosing the endometrioma.
Right, they're for mapping out the total architectural distortion of the pelvis.
Yeah.
You're specifically looking for obliteration of the pouch of Douglas, hydronephrosis, or maybe a hydrosalpinx.
Yeah, you're looking for markers of deeply infiltrating endometriosis because, let's face it, endometriomas rarely exist in isolation.
They're basically giant red flags for a frozen pelvis.
Exactly. And the structural implications of that are profound. We know that highly reactive, sticky endometriotic tissue frequently binds the ovary to the ipsilateral pelvic sidewall, or the fallopian tube, or the posterolateral uterus.
It's all just glued together.
Yeah, this dense adherence completely distorts the retroperitoneal anatomy. Which actually brings us to the most critical hidden danger during your initial laparoscopic approach.
The ureter.
Precisely. Deeply infiltrating endometriosis and dense ovarian adhesions don't just, sit nicely on top of the retroperitoneum. They actively pull the ureter immediately.
So the standard anatomical landmarks you usually rely on become entirely unreliable.
Right. The ureter might be pulled directly into the base of the ovarian fossa, like physically involved in the disease itself.
Wow. So your initial entry and mobilization have to account for that distortion. And the guidelines recommend utilizing 3 laparoscopic working ports. Can you sort of walk us through the ergonomic rationale behind that specific setup?
Sure. 3 working ports give you the angles you absolutely need for precise triangulation. Because when you're dealing with dense fibrotic adhesions, pulling the ureter out of its normal bed, you need optimal traction and counter traction.
2 ports just don't cut it, huh?
They really don't. 2 ports simply don't provide the flexibility to safely separate the ovary from the sidewall while, simultaneously keeping a clear visual on the ureter. The guidance is super clear here. Identify and trace that ureter immediately.
Even if you have to start from healthy tissue way proximal to the adherence point, right?
Exactly. Start where it's safe and trace it down.
Now, during that whole mobilization process, it's incredibly common for the cyst to rupture. Thick fluid obscures the field. And I think the natural instinct for a lot of surgeons might be to suction and widen the opening to see what you're dealing with.
Yeah, but the guidelines explicitly advise against that. You should only extend the opening just enough to expose the cavity.
Because every millimeter of incision into the ovarian cortex is a direct insult to the functional tissue.
Right. If you make multiple incisions, or if you widen a rupture unnecessarily, you are multiplying the damage to the primordial follicles sitting just beneath the surface. You really have to minimize disruption.
Sometimes just like turning the cyst inside out can facilitate access without needing any more cortical incisions.
Yeah,
Right?
exactly.
Thinking about the structural vulnerability of the ovary, I often compared the blood supply at the hilum to like a city's main power grid.
Oh, that's a great way to think about it.
Because the larger intra-ovarian vessels are heavily concentrated right there at the anterolateral aspect, the hilum, at the insertion of the mesovarium. And you can do all the localized, delicate repair work you want on the outskirts of the capsule.
But if you mess with the main lines,
Right. If you indiscriminately cut or aggressively coagulate near the hilum, you sever the primary supply from the ovarian and infundibulopelvic ligaments. You plunge the whole neighborhood into darkness.
you shut down power to the entire organ. You effectively render the ovary ischemic, regardless of how beautifully you peeled the rest of the cyst.
Exactly. You kill the ovarian reserve. So avoiding excessive bleeding in that highly vascularized zone is just paramount.
It really is. If you trigger a major bleed at the hilum, the inevitable response is aggressive hemostasis, which usually means heavy thermal coagulation. And thermal coagulation at the hilum permanently destroys healthy ovarian tissue.
Which is terrifying because peeling that fibrotic capsule inevitably risks tearing microvessels. So you are immediately faced with the next threat to the reserve achieving separation without triggering a bleed that forces your hand.
And this brings us to the first major clinical option, cystectomy, the art of the peel.
Right. Removing the cyst wall entirely begins with identifying the correct cleavage plane. You initiate this with a cold cut, right? An incision made away from those healer blood vessels.
Yeah, using cold scissors at the edge of the cyst opening prevents thermal artifact. It allows you to actually physically feel the difference in tissue density between the fibrotic capsule and the much softer ovarian parenchyma.
Now, the guidelines heavily discuss injecting saline or a diluted synthetic vasopressin solution, typically, 0.1 to 1 unit per milliliter?
Yes, directly under the cyst capsule.
Right, to aid that dissection and significantly reduce bleeding. But this is highly debated in practice. Let me push back on this a bit.
Okay, go for it.
If synthetic vasopressin makes the dissection cleaner and spares the patient from thermal damage, why isn't it just a universal standard in every single OR?
Because it requires extreme clinical coordination and it comes with serious cardiovascular risks.
Like what exactly?
Well, synthetic vasopressin is a really potent vasoconstrictor. When injected, systemic absorption can cause rapid, severe bradycardia and intense hypertension.
Wow. So you can't just inject it and assume you're good to go.
Absolutely not. You must have a direct, ongoing dialogue with your anesthesiologist. They need to be watching the monitor like a hawk the millisecond that needle goes in.
That makes sense.
And if vasopressin is unavailable in your region, or, the patient's cardiovascular profile makes it too risky, the guidelines suggest subcapsular saline injection to hydrodissect the plane, though obviously it lacks the hemostatic benefit.
Right. So assuming you've established your plane safely, you proceed with traction and countertraction. The mechanism here really relies on the physical properties of the tissue.
Yeah, you are dealing with highly adherent reactive tissue. The physical force applied during traction must be meticulously controlled.
Because excessive pulling doesn't just separate the capsule, right? It shears the underlying healthy parenchyma,
Exactly, and shearing tears the vascular bed, which immediately floods your field with blood.
which forces you to achieve hemostasis. Now, the document is really emphatic about avoiding blind or widespread diathermy here.
Yes, very emphatic. When you have a bleeding vessel on the ovarian bed, the absolute recommendation is precise, spot bipolar coagulation.
Just sealing individual pinpoint vessels, because wide application of energy basically just cooks the surrounding primordial follicles.
Right, you have to be surgical about it, literally. And once the capsule is removed and hemostasis is achieved, you face the question of reconstruction.
Well, the physical dynamics of the ovary mean that small defects will typically just approximate spontaneously, right?
They do. But for massive endometriomas, leaving a gaping defect isn't really an option. You have to restore the anatomy, which might require suturing.
And the guidelines specifically advocate for internal monofilament sutures here, which is a big contrast to using external knots or, braided sutures,
Yeah, because braided sutures and external knots act as a physical nidus for inflammation. They are absolute magnets for postoperative adhesions.
which completely defeats the purpose of an anatomy-restoring surgery in the first place.
Exactly. Internal monofilament sutures reduce that inflammatory response.
Mhm.
The guidelines also support using anti-adhesion barriers like oxidized regenerated cellulose or hyaluronic acid products to physically separate the healing ovary from the pelvic side wall.
Okay, but what happens when the physics of the tissue simply won't cooperate? Like, you've made your cold cut, you're looking for the plane, but the capsule is so fibrotic and fused to the perineuma that it's acting like concrete,
Oh, it happens. And persisting with a cystectomy in that scenario is going to physically rip the ovary apart.
which brings us to the critical pivot point in the guidelines, moving from excision to tissue-sparing energy destruction,
Yeah.
ablation.
Right. When excision crosses the line from therapeutic to destructive, we pivot to ablation. The goal shifts from physical removal to vaporizing the superficial endometriotic lining while leaving the underlying tissue totally untouched.
And the two primary modalities supported for this are laser and plasma ablation. Let's break down the biophysics of those energy sources, starting with the CO2 later. If a surgeon is setting this up, what parameters are the guidelines suggesting?
For a CO2 laser, the recommended power setting is 30 to 55 watts for the beam, or 6 to 10 watts if you're utilizing a fiber. And crucially, the laser must be used on a defocus or Surgiscan setting.
Because focusing the beam creates a cutting tool. Defocusing spreads the energy over a wider surface area, turning it into an ablative tool, right?
Exactly. The wavelength of a CO2 laser is highly absorbed by water, which means it rapidly boils the intracellular water of the targeted tissue.
Causing like instantaneous vaporization with very little lateral thermal spread.
Right. And that lack of thermal spread is exactly why it's so protective of the ovarian reserve. Now, for plasma energy, the mechanics are a bit different, but the goal is the same.
Utilize the coagulation mode, set between 10 and 40, maintaining a distance of about 5 millimeters from the tissue. And the argon plasma creates this uniform flow of energy that desiccates the surface.
Yeah, and regardless of whether you use laser or plasma, the endpoint of ablation is entirely visual. You are looking for a very specific color change in the tissue.
Right. The clinical endpoint is the complete disappearance of the reddish hemosiderin-stained tissue.
Yes. As you apply the energy, you will see the tissue turn from red to a distinct yellow-white. And the millisecond you see that yellow-white layer, you stop.
Because the endometriotic invasion in a cyst capsule is actually quite superficial.
Exactly. Continuing to apply energy beyond that visual cue is biologically useless and actively destroys the healthy follicles lying directly underneath.
So you utilize intermittent irrigation to clear away the carbon debris, maintaining a pristine visual field so you don't miss that color transition. Now, while laser and plasma are ideal, we know many clinics globally rely on electrocoagulation. But the guidelines treat electrosurgery with significant caution.
They do. The concern centers entirely on the biophysics of modulated high-frequency currents. While electrosurgery is effective for hemostasis, the heat penetration is notoriously difficult to control compared to, the predictable absorption of a CO2 laser.
If a surgeon has to use bipolar forceps, the suggested parameters are 25 to 40 watts, right?
Correct. And monopolar energy, set at 15 to 20 watts, is heavily restricted. It's essentially reserved only for highly fibrotic, difficult areas like the hilum where precision cutting is absolutely needed.
But this raises a massive physiological question for me about the Goldilocks zone of electrocoagulation. The guidelines note that an endometrioma capsule's thickness varies wildly, like up to 3.0 millimeters, even within the same cyst.
Yeah, it's very inconsistent.
So how can you possibly judge the depth of thermal destruction when the surface tissue turns white?
You fundamentally cannot. That is the exact danger the document highlights. With bipolar electrosurgery, surface blanching does not accurately reflect subsurface thermal damage.
Wow.
Yeah. The tissue temperature trapped between the jaws of a bipolar instrument easily reaches 300 to 400 degrees Celsius. And depending on how long you apply the current, that extreme heat can penetrate 10 to 12 millimeters deep into the ovary.
Wait, really? 12 millimeters of thermal spread into an organ that is only a few centimeters wide to begin with? That's insane.
It is. You are causing mass apoptosis of primordial follicles without even seeing it, which is why the recommendation is so strict. If you are forced to use bipolar coagulation for ablation, you must use incredibly short bursts of energy.
and constantly assess the tissue and continuously cool the ovary with irrigation fluid to mitigate that deep thermal wave.
Exactly. And this brings up a really critical layer of clinical context, which is patient profiling. The guidelines emphasize tailoring the approach based on the patient's fertility goals.
Right, because a 25-year-old patient whose primary goal is long-term pain relief presents a very different risk profile than, say, a 38-year-old patient who is actively undergoing IVF and simply needs the cyst volume reduced to access her follicles.
The surgical calculus completely shifts. For the 38-year-old IVF patient, preserving every single follicle is the absolute highest priority. Her AMH is likely already compromised by age and the disease itself.
So in her case, aggressive excision is just far too risky.
Right. A conservative ablation or even simple drainage combined with assisted reproductive technology might be the preferred route. But for the 25-year-old, where long-term recurrence of the cyst and chronic pain are the main concerns, a meticulous cystectomy offers the lowest recurrence rate.
And her younger, more robust ovarian reserve might better tolerate the physical trauma of the peel.
Precisely.
Okay, so we have the art of excision and we have the physics of ablation. But what happens when you open the pelvis and you are staring down an endometrioma so deeply embedded at that highly vascular hilum that pure excision risks severe hemorrhage? But pure ablation isn't sufficient for the sheer volume of the disease.
This is where we move into advanced hybrid strategies. For complex lesions near the hilum, the guidelines recommend the combined technique.
Sparing the power grid.
Exactly. You begin with a standard cystectomy, finding the cleavage plane and stripping away 80 to 90% of the cyst wall. But as your dissection approaches the Huller vessels, you stop.
You just leave it.
Yeah, you deliberately leave that final 10 to 20% of the capsule attached to the hilum. You abandon the traction. Then you switch your modality.
Ah, okay. So you bring in your CO2 laser, your plasma energy, or highly controlled bipolar, and you ablate the remaining remnant right there in situ.
You've got it. You achieve maximum disease removal through excision, but you protect the primary blood supply by switching to superficial ablation at the most critical juncture.
It's a really elegant anatomical compromise. But what about the truly massive endometriomas? The cysts that dominate the entire pelvis, where attempting even a combined approach on day one is virtually guaranteed to result in massive ovarian trauma.
That's where the guidelines introduce the multi-step approach, and this requires significant preoperative patient counseling because you are actively planning for multiple interventions. It's really a biological strategy, not just a surgical one.
I look at this approach a lot like the concept of neoadjuvant chemotherapy in oncology, or like a tactical retreat in a really difficult video game boss fight.
I love that comparison.
Right, because instead of risking everything in a chaotic first encounter, you hit the pause button. You cast a shrinking spell, the therapy, and come back for the final battle when the boss's defenses are weakened.
That is exactly the biological mechanism at play here. So, step one is a purely diagnostic and decompressive laparoscopy. You drain the thick fluid to relieve the immediate pressure. You take a biopsy of the cyst wall to definitively rule out malignancy, and then you stop.
You leave the capsule totally untouched.
Completely untouched. Then step two introduces that neoadjuvant element. The patient is placed on a GnRH agonist therapy for roughly 3 months.
How does that chemically alter the surgical landscape you're going to face in step 3?
Well, the GnRH agonist induces a profound hypoestrogenic state. And since endometriosis is an estrogen-dependent, highly inflammatory disease, by shutting down that hormonal stimulation, you downregulate local inflammatory and angiogenic factors.
So the cyst wall actually undergoes physical atrophy.
Yes, you significantly decrease the thickness of the pseudocapsule, and you physically shrink the stromal vascularization. You are chemically starving the tissue's blood supply.
Wow. So when you return 3 months later for step 3, the second laparoscopy, the anatomical reality is entirely different. The cyst is drastically smaller, the tissue is less inflamed, and the vascular bed is suppressed.
Exactly. You can now definitively remove or vaporize that cyst wall with just a fraction of the risk to the underlying follicles.
It drastically lowers the intraoperative risk. I mean, yes, it burdens the patient with a second procedure. But the clinical trade-off is the preservation of her fertility and a much safer management of a massive hostile cyst.
And the guidelines make a profound point here. If a procedure is simply too difficult to perform safely by laparoscopy on the first attempt, pausing and shifting to a multi-step approach is infinitely superior to risking a laparotomy or causing catastrophic damage to the ovary.
Yeah. The document explicitly states that laparotomy is rarely indicated for benign endometriomas, regardless of how large they are. If the laparoscopic environment is too dangerous, you drain it, you utilize the GnRH agonist, and you come back.
Or you refer the patient to a specialized expert center. The ego of completing the surgery in one go absolutely must take a backseat to the physiology of the patient.
Knowing when to pause is perhaps the most advanced surgical skill of all.
It really is.
So, as you head into the clinic or the OR tomorrow, what is the ultimate takeaway from this joint consensus from ESGE, ESHRE, and WEP-US? It's the absolute confirmation that treating ovarian endometriomas is a highly individualized, dynamic process.
Yeah. Your surgical choice, whether it's a delicate cystectomy with cold scissors, a precise CO2 laser ablation, or a patient-counseled multi-step approach, is dictated by the unique architectural distortion of that specific pelvis.
The depth of the cyst, its proximity to the ureter and the Hiller vessels, and the patient's age and fertility timeline dictate every move you make. The prime directive is achieving maximum disease elimination while inflicting minimal collateral damage to the healthy ovarian parenchyma.
Perfectly said.
And I want to leave you with a final thought to mull over. Throughout this entire document, the focus is necessarily reactive. It's about what to do once the endometrioma has already formed, already grown massive, and is already threatening the ovary structure.
Right. We're dealing with the aftermath.
But buried in the broader research surrounding these guidelines, there is a persistent, quiet focus on diagnostic blood biomarkers. Now, currently, their diagnostic accuracy is heavily limited. Endometriosis is a complex inflammatory condition, and current markers are often pretty nonspecific.
They definitely cannot yet replace direct visualization.
But consider the trajectory of our field over the next decade. Advancements in identifying non-invasive, hyper-accurate blood biomarkers are accelerating. Just imagine a future where we catch endometriosis chemically at the microscopic level, years before it ever forms a visible chocolate cyst.
Oh, that would completely redefine gynecological care.
Right. Imagine how your practice and this entire surgical tightrope will evolve when we can diagnose the disease before the retroperitoneal anatomy is distorted, before the ureter is pulled out of place, and before the ovarian reserve is ever threatened.
The focus would shift entirely from complex anatomical reconstruction to early, non-invasive medical intervention. It replaces the scalpel with early detection.
Exactly. Until that day arrives, though, you are still the one standing at the table, navigating a distorted pelvis and making those split-second decisions to protect your patient's futures.
And it is not an easy job.
It isn't. But hopefully, with the biophysical principles and advanced strategies from these guidelines in mind, your footing on that surgical tightrope just got a little more secure.
Keep up the vital, incredible work you do for your patients every single day.
Thanks for taking this deep dive with us.